Here is something most people never hear from their doctor. The blood pressure target you are being told to aim for, 120/80, was established primarily through research conducted on middle-aged adults. And applying that target to a 70 or 80-year-old body does not always protect you. In some cases, it actively increases your risk. Not because the research was wrong, because the body at 70 is physiologically different from the body at 45 in ways that change what a given blood pressure number actually means, and what the consequences of aggressively lowering it can be. Today we are going through exactly why that is, what the evidence supports as a realistic target for adults over 70, the specific warning signs that your current treatment may be set too low, and one simple test you can do at home tonight that tells you whether your blood pressure is behaving safely when you change position. Why blood pressure becomes more complicated after 70. Blood pressure management in younger adults is relatively straightforward. High is bad, lower is safer. Treat toward the standard target. The evidence for that approach in middle-aged adults is clear and consistent. After 70, the picture becomes significantly more complex for three specific biological reasons. First, arterial stiffness. As we age, blood vessel walls become progressively less elastic. This stiffness naturally pushes systolic pressure, the top number, higher. It also means the cardiovascular system loses much of its ability to make rapid adjustments to blood pressure in response to position changes, hydration status, temperature, and physical activity. The system that once responded fluidly now responds sluggishly. Second, baroreflex decline. Baroreceptors are pressure sensors embedded in major blood vessel walls. Their job is to detect sudden blood pressure changes and signal the heart and blood vessels to compensate instantly. In younger adults, standing up triggers an immediate baroreceptor response that maintains blood flow to the brain within seconds. With age, this response slows. The gap between when blood pressure drops and when the body compensates grows longer, and during that gap, the brain receives less blood. Third, reduced physiological reserve. An older body has less capacity to absorb and recover from cardiovascular stress. The same blood pressure drop that causes a young person to feel briefly lightheaded can cause an older person to lose balance, fall, and fracture a hip, with consequences that can permanently alter independence and quality of life. These three changes mean that in older adults, the risk equation for blood pressure treatment shifts. The risks of high blood pressure remain real, but the risks of overtreating, of pushing blood pressure below what the individual body needs to maintain adequate perfusion, become equally real and are far less often discussed. The problem most guidelines do not acknowledge here is a fact about blood pressure research that most patients are never told. The large clinical trials that established current blood pressure targets, the trials whose numbers became the guidelines your doctor follows, systematically excluded the oldest and frailest patients, people over 80, people in care facilities, people with significant frailty, multiple chronic conditions, or cognitive impairment. In other words, the evidence base that produced the 128 IFS target was built almost entirely on adults who do not represent the population for whom that target is most aggressively applied later in life. This does not mean guidelines are useless. It means they are population averages derived from selected populations, and applying them without individual adjustment to adults in their 70s and 80s is where clinical harm most often occurs. The question is never simply, what is the guideline? The question is, what is right for this person, at this age, with this physiology, taking these medications? Orthostatic hypotension. The risk most people ignore, the most common and most dangerous consequence of overtreating blood pressure in older adults, is orthostatic hypotension, a drop in blood pressure that occurs when changing position from lying or sitting to standing. You may already recognize it. That momentary dizziness when you get up from a chair, the blurred vision at the edges when you stand up too quickly in the morning, the lightheaded feeling when you step out of a warm shower, the need to grab something solid for a second before your equilibrium returns. These moments feel minor. They are not. In older adults, a blood pressure drop of 20 millimeters of mercury in the top number within 3 minutes of standing, the clinical definition of orthostatic hypotension, is associated with significantly elevated fall risk, cognitive decline, and cardiovascular events. And blood pressure medication is one of the most common causes. Here is a simple test you can do at home. You need a blood pressure monitor, available at any pharmacy for around $30. Lie flat and rest for 5 full minutes. Take your blood pressure while still lying down and record both numbers. Stand up immediately and take your blood pressure again within 1 to 3 minutes. Record both numbers. If your systolic pressure, the top number, drops by 20 or more points upon standing, that is orthostatic hypotension. If your diastolic, the bottom number, drops by 10 or more points, that is also significant. Either finding, in someone on blood pressure medication, is a conversation your doctor needs to have with you. This test takes 10 minutes. It costs nothing beyond the monitor, and the information it produces is more clinically relevant to your daily safety than most readings taken sitting in a clinical setting. What the blood pressure target should actually be after 70. The honest answer is that there is no single correct number that applies to every person over 70. Anyone who tells you otherwise is giving you a guideline, not an individualized answer. But based on the available evidence, including data from studies that did include older adults specifically, here is a reasonable framework. For adults between 65 and 74 who are otherwise active, mobile, and tolerating treatment well, a systolic target below 140 is reasonable. Some evidence supports targets closer to 130 for this group, particularly for those with cardiovascular risk factors and no significant orthostatic symptoms. For adults 75 and older who are fit, cognitively intact, and free of significant frailty, a target of 130 to 145 is generally appropriate. The evidence for aggressive lowering below 130 in this age group is weaker, and the risks of overtreating are more pronounced. For adults 75 and older who show signs of frailty, defined not simply as age, but as unintentional weight loss, exhaustion, weak grip strength, slow walking speed, or low physical activity, a more conservative target of 140 to 150 is increasingly supported by geriatric medicine evidence. In this group, the risk of falls and the consequences of falls often outweigh the long-term cardiovascular benefits of aggressive blood pressure lowering. How do you know if you fall into the frailty category? 5 markers are used clinically: unintentional weight loss of more than 10 pounds in the past year, exhaustion most days without clear cause, weak grip strength, difficulty opening jars or turning doorknobs that were manageable before, walking speed that has slowed noticeably, physical activity that has significantly declined. If 3 or more of these apply, frailty is clinically relevant to your blood pressure management and should be explicitly discussed with your prescribing doctor. Warning signs that your target may be set too low. Your body sends signals when blood pressure is being pushed below what it needs. Most people dismiss these as normal aging. They are worth paying attention to. Dizziness or lightheadedness when standing, the orthostatic hypotension already discussed. This is the most direct signal. Fatigue that has worsened since starting or increasing blood pressure medication. If your energy dropped meaningfully after a medication change, blood pressure that is too low can reduce blood flow to organs and tissues in ways that produce persistent fatigue. Increased frequency of falls or near falls. If you are catching yourself on furniture or walls more often, this is a clinical concern, not a normal aging expectation. Brain fog or memory changes that coincide with medication changes. Cerebral perfusion, blood flow to the brain, depends on adequate blood pressure. In older adults with some arterial stiffness, the brain may need a higher baseline pressure to maintain adequate flow. Symptoms of reduced cerebral perfusion can include difficulty concentrating, word-finding problems, or generalized cognitive slowing. Cold hands and feet that have worsened. Peripheral circulation depends on adequate blood pressure. Consistently cold extremities can reflect inadequate perfusion pressure. None of these symptoms are proof that your medication is causing harm. Many have other explanations. But if they appeared or worsened after a medication change, they deserve a specific conversation with your doctor, not just reassurance that they are part of getting older. The conversation to have with your doctor. The most useful thing this video can do is help you walk into your next appointment with specific, clear language. Rather than "I feel a bit off," say, "I have been getting dizzy when I stand up, and I would like to discuss whether my current blood pressure target is still appropriate for my age and health status." Ask specifically, "Is the target I am aiming for based on evidence from adults my age or from younger populations?" Ask, "Is there a way to check whether my blood pressure is dropping when I stand up, either in the office or through home monitoring? If you have noticed any of the warning signs above, since my medication was changed, I have noticed specific symptom. I want to understand whether this could be related to my blood pressure being treated too aggressively." These are not adversarial questions. They are the questions that allow your doctor to treat you as an individual rather than as a number on a guideline. What this video is not saying, to be explicit, this video is not suggesting you stop your blood pressure medication. Untreated high blood pressure causes real, serious, well-documented harm: stroke, heart attack, kidney disease, heart failure. Most people on blood pressure medication are on it for good reason, and the decision to treat is almost always the right one. The argument here is much more specific. The target matters, the individual matters. And in adults over 70, especially those with frailty, orthostatic symptoms, or significant medication burden, the goal of treatment is not always the lowest achievable number. It is the number that reduces long-term cardiovascular risk without creating the fall risk, cognitive impact, and quality of life burden that overtreating can produce. The safest blood pressure in an older adult is not always the lowest one. It is the one that is right for that person. If this gives you a clearer picture of why blood pressure management after 70 is more nuanced than a single target number, and the language to have a more specific conversation with your doctor, please share it with someone managing blood pressure in their 70s or 80s. Subscribe for more evidence-based health content designed for adults over 60. We will see you in the next one.